Good afternoon, everybody. This is Leo talking from Toronto, and I would like to welcome all to the Spring 2015 CPT Agent session. As a reminder, we are using a program called GoToWebinar to record and webcast or broadcast this session, if you will. Before we begin, allow me to go a few points for overview housekeeping details. Number one, we will do the question and answer session by region at the end of the session. I would like to remind all that your questions can be made verbally, and if you don't mind, sending us or pressing on the hand button at the right side of your screen so that I can unmute your button as you raise your hand. You can also type the question in and place it into the question box on your control panel to send me the question so that I can bring it to the presenters at the end of the session. For the Sick Kids team, I would ask them to also ask their questions once we are actually reviewing the questions at the center that pertains to you. And the question, Sick Kids. At the end of the session, we'll also be receiving an evaluation survey for this session that will appear at the end of the webinar. I would ask you to please take a minute to complete that form, as we will be reviewing the overall evaluations of the 4 webinars of this academic year in Halifax in 1.5 weeks' time. Fourth, if you require any technical assistance in participating or encounter any problem, please enter your comments in the question box. Only I will be able to view it, and you won't be interrupting anything. Alternatively, please call me directly at 416-813-7654, extension 205401. We will now start introducing our 2 speakers for the webinar entitled EmPoWARed, Warfarin Self-Management in Pediatrics. Dr. Aisha Bruce is well known to all of us. She is a pediatric hematologist working at the University of Alberta, Edmonton, and she is specialized in pediatric thrombosis, which is one of her main research interests. She is dedicated to the care of children with thrombosis and or on anticoagulants, working in many instances such as the KidClot team to improve care through a broad spectrum of clinical and research endeavors. She, as I alluded to, will be sharing some thoughts on the issue of pediatric thrombosis, quality of life in children on anticoagulation. Our second speaker for today is Mary Bauman, who's also very well known to all of us. Initially working as a nurse under the auspices of Doctors Maureen Andrew and Patty Massicott, she completed her master's in nursing and became a nurse practitioner in approximately 10 years ago, just after transitioning from Toronto to Stollery Children's Hospital. Her current role includes independent inpatient clinical management, as well as overseeing the outpatient anticoagulation program. And her research focus is on the clinical management of children on anticoagulants. So without further ado, I will welcome our 2 stellar speakers to share their thoughts with us on anticoagulation, or more specifically, warfarin self-management in pediatrics. So we will bring the slides to the screen and open up the mic of Aisha and Mary. The floor is yours. Thank you very much for agreeing to present.
Can you see our screen?
Yes, we can.
Okay, excellent. All righty. Okay. This is Mary Bauman. Thank you for the opportunity to present to you this afternoon. This is a topic that I have been very passionate about, and I'm excited to share our findings with you. So the topic for today is empowered warfarin self-management in pediatrics. The objectives of today are really to review very briefly the current landscape of warfarin outpatient management for children, review the current models of care, and to describe our pediatric patient self-management study, which is the EmPoWARed study. And then Dr. Bruce is going to describe the quality of life and focus group data that resulted from the EmPoWARed study. So the first question we get when we first present or are asked to speak about warfarin self-management is, well, who cares? What about the new NOACs? And we all know that in pediatrics, we're in the very, very early phases of using NOACs, and in fact really are only at the very early stages of collecting PK/PD data and finding doses that are appropriate. So we're a long way off in the pediatric world compared to adults. In addition, there is no monitoring, which is a huge benefit. It does provide a stable effect, but they're still not approved for all indications, certainly not studied in children. They're not reversible, which is problematic in pediatrics, given the activity level of toddlers and younger children, and there's a huge cost associated with those that makes it challenging for many of our patient family units. So it takes us back to thinking about warfarin therapy and what the greatest challenge is. The greatest challenge is really adherence to ongoing therapy. And if you look at a commissioned report in 2003 by Sabati et al., adherence to long-term therapy for chronic illnesses in general is less than 50%. And the consequences of poor adherence to long-term therapies are poor health outcomes for the patient, increased healthcare costs related to decreased effectiveness, decreased safety of the agents that are or the therapy prescribed, and these costs are both social and personal. If you apply this 50% adherence, or you think about the adult populations and looking at adherence, and also looking at the Dutch registry, we know that time in therapeutic range for children going to the laboratory for INR testing and for adults is less than 50%. So that speaks very clearly to decreased safety and efficacy of the prescribed treatment. So our goal really is to improve adherence. So because warfarin is not well adhered to, it's a challenging drug to manage, it's bothersome for patient family units, maximum efficacy is not realized. And that costs approximately $1.4 billion US yearly. As I've alluded, time in therapeutic range is only 60% and 50% reported by Ansel and Strife. And the other challenge is that thromboprophylaxis is preventative rather than a treatment. So in most cases, our children have not had a clot. They may have a mechanical valve, they may have a Fontan, they may require thromboprophylaxis for not treatment of an event or a thrombotic event, but more as prevention of an event. So often families find or believe it to be less important. There's fear associated with risk of bleeding on behalf of the parents of the children, and frequency of INR testing really interrupts life. It interrupts school, it interrupts parents' work, presents daycare challenges if there's additional siblings, etc. And finally, children are on it for multiple patient treatment years. And so they don't start when they're 65, they're starting when they're 3 or 4 and are on anticoagulation for life. One of the solutions to the challenges of adherence with warfarin management is the use of a coagulometer. There are multiple models that are used. Within Canada, the model that is most readily available is the CoaguCheck XS through Roche. The other models are more available in the States, but really if you look at the literature, the CoaguCheck XS is the one that has been most commonly used and most often reported on. If we look way back into 2004, way back then, monitors or coagulometers were demonstrated to be accurate and precise. However, the controversy continues, given that there are discrepant INRs between a meter and a laboratory INR. But this must be viewed in the context of the inherent inaccuracies of INR tests. For example, if I was to take one sample of blood and send it to Toronto to be analyzed and analyze it in our laboratory here in Edmonton, I would get two different INR results. Although the INR was intended to account for those differences in reagents and technologies, it really is not as good as had been hoped. So when looking at accuracy and precision of a coagulometer, there are really three components that you want to look at. The first one is accuracy. So doing a laboratory plasma INR and one on the meter at the same time. Doing them 12 hours apart or a day apart is really not going to be a measure of accuracy. And really, when you're looking at accuracy, you want to know, are they the same value? Now, if you look at the inherent inaccuracies of INR tests and laboratory standards, a difference of less than 25% is considered satisfactory. Within our program, we accept only a difference of approximately 15%. The other way of evaluating accuracy is to say, well, the INR should be within 0.5 of each of the tests. One of the challenges with that is that we know on meters, once the INR is greater than 5, the 15% is a much higher number than it is for an INR of 2. So you're going to be well outside of the 0.5 range. With regards to precision, you're going to take the same blood sample and apply it to multiple meters and on the same meter repeatedly, and again, find out whether the result is the same. Is it repeatable and reproducible? And they are. And finally, I think what is often not thought about is the clinical relevance. So does the difference in the INR result in a different dose decision? Rose et al. Published in 2008 on clinical relevance of different INRs. And if the INR does not result in a different dose decision, then it's deemed to be not clinically relevant. And that occurs in more than 80% of INR test comparisons. One of the big concerns is this INR greater than 5 and the discrepant results. However, if your INR is greater than 5 and the variation between the meter and the lab is larger than 15 or 20%, it's not going to change your clinical decision. You're still going to hold your dose of warfarin. So it's important to keep this in mind when looking at the use of a coagulometer for INR testing. There's a number of models of care for warfarin management. Dedicated anticoagulation clinics have been well described in the literature. Family physicians will often do it. Community clinics, there may be point-of-care INR meters, coagulometers placed into community clinics for INR testing. Patient self-testing is when the patient is educated and demonstrates competency in INR testing using the coagulometer and then reports their INR to the health team for warfarin dose decision making and for the next INR test date. Up until 2008, this was the standard within our program at Stollery Children's Hospital. All of our children are discharged home on INR meters, and the source of the INR meters was a very small grant for initial research that provided 10 meters. And since then, it has been a growing program, and donations and patients have purchased them that refilters into the program. So it's been a model that has been financially sustainable. Patient self-management takes patient self-testing a step further. And patients participate in comprehensive education about warfarin, so more detailed than they get with the patient self-testing, its interactions, diet, illness, medication, or error, warfarin dosing, and testing frequency. They must demonstrate competency on performing an INR test to ensure the accuracy of the results. And they are provided an algorithm for dose adjustments, and then we teach them to personalize the algorithm. In 2005, Jack Ansel demonstrated and published that outcomes were as good or possibly better than anticoagulation clinics And at that point, he had identified that health-related quality of life was improved and that the use of a coagulometer is cost-effective to the overall health system. At that point in time, he did identify critical elements to the success of a PSM program. One of them is selection of suitable patients, course completion, intellectual capacity, or thought to be so, having coagulometers, education and training, ensuring that the trainers are competent, training the patients, and monitoring and support to PSM patients must continue, although they are practicing patient self-management. When we look at pediatric studies evaluating either PST or PSM, there are a number of previous studies. Importantly, the time and therapeutic range, rather than 50% for children going to the laboratory, increased to between 64 and 84%, providing improved safety and efficacy of warfarin therapy. There was an associated patient preference and increased health-related quality of life with use of a coagulometer. This took us to our EmPoWARed study concept. So our first study was an RCT that we published in 2012. And this was an RCT where we took our patients who were already performing self-testing for greater than 3 months, and we randomized them to continued patient self-testing versus patient self-management. And our objective was to evaluate safety and efficacy of PSM, with the primary outcome being time and therapeutic range as a surrogate for safety and efficacy, and health-related quality of life. We ran this study for 1 year. The concept of the study is exactly, and the methods is exactly as I'll describe in the EmPoWARed study, but the outcomes were so positive and the improved health-related quality of life and patient preference was so high that it really mandated us to move forward and offer patient self-management to all patients within the program, and this is now our standard of care. Our objectives really were to determine the sustainability of patient self-management over time. So is this something that patients would learn to do initially and they would be very keen and then they would get lazy over time, or was this something that was going to be sustainable? And did it have a positive impact on their life? And so the way we looked at the EmPoWARed study is we ran the study for a 5-year period, and we compared the first 6 months on independent patient self-management with the outcomes of the last 6 months on independent patient self-management. And our secondary aims were really quality of life on patient self-management. Our eligibility criteria was they had to have been on warfarin therapy for greater than 3 months, and they had to have been performing patient self-testing for greater than 3 months. We felt that this provided patients with a baseline of knowledge from which they could move forward. They needed to be fluent in English. We needed to be able to communicate them, and we needed to be able to evaluate their knowledge. And they had to attend clinics, follow-ups with us every 12 to 18 months. Each year, over the 5-year period, we held new PSM clinics, and patients were enrolled yearly into these groups. Some patients would have stopped their anticoagulation therapy, some had grown into adulthood and been transferred off, and some were on for the complete 5-year duration. So you'll see that the numbers kind of vary a little bit. So our methods really is we consented our patients. We would do a classroom education session. So we bring in anywhere between 10 and 15 patient family units at a time, and we provide education in a classroom setting, similar to what they would do in patients with type 1 diabetes. Following the classroom setting, which included case scenarios, the warfarin knowledge assessment, focus groups, quality of life assessments, which Aisha will talk about. Once we were comfortable with their knowledge, we allowed them to proceed into a 3-month apprenticeship period. During this apprenticeship period, they would test their INR at home and still call us with the result. However, the difference being that this time they would advise us of what they wanted to do with their warfarin dose, what decision they thought was appropriate for the existing INR and when they would next test their INR. This facilitated a period where patient family units could continue to learn. And so they may be making correct decisions or what we think are correct decisions, and we say, good job, on you go. That was the right decision. Or if we think that their decision may not be what we had decided, then it gives us an opportunity for discussion. And they can explain to us why they made the decision they did, which really facilitates them learning to personalize the algorithm based on the events that have occurred within their child's life over the last week that may have influenced the INR and the warfarin dosing. We have a web-based INR entry system, which I'll describe, and we actually followed them for 6 years in total. This is just an example of our teaching aids. We have child-focused education materials that we use. Our goal is really to begin educating children on warfarin when they're starting at 7 years of age. Prior to that, we start educating them on the meter. We have many children who are 4 and 5 years old, and they can do the entire INR test on the coagulometer independently, with the exception of actually poking their finger. And so children learn very early. Our goal with warfarin knowledge is that by the time the child is 12 or 13 years of age, that they should be able to have sufficient knowledge to be able to make warfarin decisions that are reasonable and competent in preparing them for adolescence and into adulthood. mHealth is a new, it's an up-and-coming way to improve adherence, and it's really the use of mobile and wireless services to manage warfarin. And they can act as virtual physicians or healthcare provider extenders. There's multiple programs that are used by the adults in terms of INR modeling or warfarin modeling and with INR testing. Our website was developed specifically for INR entries by the patient. And the website can be downloaded onto the homepage of their cell phone. And when the INR is tested, they enter their INR immediately, their warfarin dose decision. Any changes in DIME, diet, illness, medication, or errors such as missed doses or double doses, and what their next INR date will be. As a health provider, we are able to see all patients and review all of their entries. As a patient or a patient family unit, it is encrypted and you are only able to see your own data. In addition, INR reminders are sent to the patients to remind them to test their INR on the dates that they have chosen. And there are also direct links to the Kid Clock program for support as needed, and there are resources available online as well. So our demographic results really is that the median time, because children would come on and off of therapy, was 2.7 years, but some children were on as little as 1 year and as much as a total of 6.2 years, which was the duration of the study. Any child that was on for less than, any data from children who were on less than 1 year was excluded because we weren't able to effectively compare the first 6 months with the last 6 months. We had a varied number of indications, but as you can see, the majority of them are long-term thromboprophylaxis. So here's our data that we've had. So time in therapeutic range, when we compared, this is patients on self-management who had learned to make their own warfarin dose decisions. In phase 1, our time in therapeutic range was 90%. And in phase 2, it was 92.9, almost 93%. Our knowledge score really was to evaluate knowledge that PFUs had to ensure that they had the basic knowledge that we felt was necessary for them to be competent or to be able to make good decisions, and that they understood the complexity of warfarin. This is a tool that we've been using since 2005 and has well validated, and the knowledge scores were sustainable over time at 92%. What's interesting is that initially, and Dr. Bruce will speak to this in more detail. The patients were doing INRs every 10 days as a mean. Okay, there were 18 INRs done in the first 6 months of their PSM time, and it decreased down to 10.5 days, or 10.5 tasks, which was every 17 days, so approximately every 2.5 weeks. We do know that increased frequency of INR testing is associated with a higher time in therapeutic range. However, I think that this significant decrease was related to patients' anxiety and then becoming comfortable in their warfarin dose decisions over time. INRs greater than 5 were minimal, INRs less than 1.6 were minimal. For each of those occurrences, patients are required to page the kid clot provider on call to advise us of the INR and for us to assist with their warfarin dose decision to get them back in range as safely and quickly as possible. When we look at errors, it's really not errors, but we review the website and we look at the numbers of times patients made a decision regarding either their INR dose or their testing frequency, which would not be consistent with what we would recommend. And as you can see, those errors were very, very low. And the number of calls to kid clot for support were minimal, but patients were comfortable to call when they felt that they needed support. We were interested in any variables that would influence patient success at patient self-management. Because when you look in the literature and they talk about patient self-management, they use the term suitable patients, but suitable patients is never defined. And so our thinking is that, well, you know, if they're more highly educated, they're a higher socioeconomic status, they'll be more successful because they'll be more capable at self-management. And in fact, we found that there were no variables that we could identify that were related to their success at PSM. Now Dr. Bruce is going to talk to you about the focus group results.
So hi everyone, it's Aisha Bruce. So I'm going to talk about the EmPoWARed study, the health-related quality of life and focus group data, as well as transition to adult care, as this is a kind of a sub-study for us. So where we're going to start is what is quality of life, and look at some quality of life measurement in intervention studies. Quality of life was defined by the WHO as an individual's perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. So as you can see, it's really an individual's perception of their entire life and their own viewpoint. And so it's hard to capture. So what are the benefits to measuring it overall in the intervention studies? Quality of life can distinguish and has been shown to be able to distinguish between drugs and therapies with apparently equal efficacy and safety. It can provide patient-reported outcomes that might not be captured otherwise in hard data. And it can lead to increased engagement of patients in decision-making and in self-care. In terms of quality of life with point-of-care INR testing, this is some of the data from mostly the adult literature. So Krumhecke et al. Published in the Lancet in 2000, and he evaluated patient satisfaction with patient self-testing versus lab-based testing. So patient self-testing or home monitoring leads to improved patient satisfaction over lab-based testing. Gedesser et al. Published in JPH in 2003, quality of life with patient self-management versus a dedicated anticoagulation clinic, and found that PSM patients demonstrated higher quality of life at 6 months than those who were cared for at the dedicated anticoagulant clinic. The only pediatric study that I am aware of was by the Australian group, Sophie Jones and Paul Monagal, in 2013, and they looked at patient self-testing versus lab-based testing when they rolled out their point-of-care testing program, and they found significant improvement in health-related quality of life for the participant, their family, and their child with PST. So again, what about the NOACs? This is some interesting results. So for the NOACs, Mons et al., there was a 2013 RELY sub-study published for this was quality of life on warfarin versus dabigatran in atrial fibrillation patients. What they found that there was no difference in health-related quality of life, and that health-related quality of life was stable throughout the entire study. So they weren't deterred by this, and the CardioVerse study was published in 2014. Same patient population, quality of life of VKAs versus dabigatran with AFib, and they had 416 patients in that study. When anticoagulation was first initiated, there was an increase in the health-related quality of life in the dabigatran group versus the warfarin group. However, by 6 months, there was no difference observed between dabigatran and the VKAs. And this is really reflective of the fact that health-related quality of life picks up major changes in your life, and a period of acclimatization can be expected with those major changes. So moving on to the EmPoWARed data. First of all, one of the quality of life measurements we used a number, but the main one we used was the KidClot Pediatric Anticoagulation Inventory, or the KidClot PAC-QL, which is a pediatric anticoagulation specific tool for warfarin. There's two different inventories, a child inventory for those between 8 and 18 years of age, and a parent proxy inventory. It's reliable and validated for use. So the KidClot PAC-QL was completed pre-PSM while the patients were on PST, and at the end of the study at the follow-up. And focus groups were held 1 year after initiation of patient self-management, and then annually to determine if any additional patient relevant outcomes came up. And so this is just some interesting interim data that I thought I would present. It's similar to the dabigatran data actually, where patients, these are the parents, their quality of life actually decreased in that first year. However, the focus groups showed us that increased responsibility actually resulted in increased anxiety, but also a sense of autonomy. So when asked, the families wished to remain on PSM. So overall, there was a statistically significant increase in health-related quality of life scores for the parent proxies, as well as the child and teens pre versus post PSM. From the focus group data, we came up with a number of themes, but basically families described increased participation and investment in their health. They felt it was a terrific program and they felt fortunate to be part of it. Communication was one of the themes, and it really inspired communication between all different levels, between parents and children, between staff and parents, between the parent dyads and other members in terms of friends and other caregivers. They felt it influenced their relationships. They said that one teen said, "My friends are become more aware I'm on warfarin," and another parent said that there was shared responsibility for managing health. Autonomy was a theme, and one parent actually said to us they felt more empowered while on the program. Lifestyle themes, they felt it was a good experience. It was simpler. It was way better for rural families. They felt not tied to the hospital. There were no disruptions in their life. Travel was also a big theme in this with their lifestyle, that they could travel to other countries without having a lot of concern or worry, and access with time changes and able to contact our team. Technology, less trips to the hospital for testing, and the fear of needles had decreased, and this is specifically about the point of care machines. So what about transition to adult care? Like I said, this is a sub-study we're working on. So as you're aware, there are a number of challenges in adolescence which interfere with the goals of anticoagulation. There's a lack of studies in terms of safety and effectiveness. And with normal adolescent physiology, there's obviously normal brain development, so it requires a different approach to education, looking at ways to ensure adherence that might be different, learning to facilitate autonomy with these young teens as they become completely autonomous, and transition to adult services. So one of the ways that our team has worked with this is looking at web-based, which you can, our website that you can see on the left-hand side here. But really, the web-based dosing algorithms in adults do not take into account adolescent behaviors, such as missed doses, alcohol ingestion, or other risk-taking behaviors. adolescent-focused education needs to be a key part of the education program, as well as entering information, like I said, on a web-based interface with their INR doses, their dosing changes, and recent behaviors. It's a very non-threatening environment for a teen, and they quite prefer technology as an aid. Healthcare practitioner alert for out-of-range INRs. They all come to the KidClot team directly from the website. And healthcare practitioner, then we evaluate their warfarin, adolescents' warfarin dose decision-making and can intervene when necessary. So this is the safety and efficacy data from our young adults. It's similar to the tables that Mary presented at the top across, on the left here you can see the outcome measures on the left-hand column, and then you have the phase 1 for the first 6 months, the last 6 months, and then the p-values on the right. So time and therapeutic range for the adolescents was actually excellent throughout, and acceptable even with a slight decrease. The knowledge scores were excellent throughout with our teen populations. The number of INR tests dropped from 24 to 12, so half within that, and as you can see, it's highly statistically significant. Again, probably comfort and knowledge in testing their, in their dose-making decisions. Their INRs out of range weren't significant, neither were their low INRs. And they didn't really make a lot of dosing errors or call a lot for support. They didn't actually need to. As previously noted, they did demonstrate an increased health-related quality of life and autonomy over time. So moving on to cost analysis, we didn't actually perform a formal cost analysis during the study. However, we did a calculation, and if you look at the total number of INRs completed in a 6-year period, there were 8,195, which equals an average annual INRs of 1,365. So the average calls received of the total INRs, which is roughly 5%, is equal to 68 calls annually. So that's 1,297 calls we are not taking, so 1,297 interventions saved at roughly $50 an hour is equal to about $16,212 savings per year in healthcare time, practitioner time alone. And cost of the POC INR versus lab is roughly equal. However, the cost is passed on to the patient in comparison to the public system when you're going from lab to POC. There is decreased events with increased time and therapeutic range with this program as well. So patient self-management is the most cost-effective option when feasible. So what about considerations if to start or to implement a point-of-care INR testing program, if that's a consideration for some programs out there? One, you need the coagulant check meters or a coagulometer and test strips and access to it for your families. You need to look at quality assurance with lab meter validations as well as the patient who is able to perform the test and has the cognitive function to know what to do with the test. Look at staff and patient education, which needs to be comprehensive. Quite in-depth warfarin teaching needs to occur in terms of warfarin actions, interactions, and management strategies, as well as proficiency meter testing needs to be performed on a yearly basis, or at least we do it on an annual basis. Monitoring and support. The process for reporting INRs, there's many different ways of doing this, as you're all aware. So phone, text, email, log, or websites are all good options. So in conclusion, patient self-management has been found to be safe and effective management strategy in children, adolescents, young adults, and adults with a developed healthcare support system. The success of PSM was sustainable over time with maintenance of time and therapeutic range. There was increased health-related quality of life and patient autonomy with PSM over time, and it eases adolescent transitions. It is effective and cost savings. So the EmPoWARed study has now been accepted for publication in thrombosis research. Really, Mary and I are presenting this on behalf of our team and the children and families who really eagerly participated in this study. Families really wanted to be part of this study, and they really didn't want to stop. Our co-investigators, Dr. Patty Mazencott, Suzanne Siddons is our outpatient RN, Stefan Coulet is a statistician who works with our team, Adam Sediak is our webmaster, and Dr. Lauren Bolster, who's our transition physician. Thank you.
Thank you very much, Mary and Aisha, to share your results, these superb results on anticoagulation and on your experience on building this outpatient anticoagulation program that is really exemplary to all of us. Let me go through, I have several questions, but maybe I'll go from west, opening the microphone to BC Children's, asking John if he has any questions to ask. John, how are you? And any questions to us?
Leo, I'm well. I know I'm in trouble because you always start from the west, and I was actually coming in and out of my clinic. But I think it's a superb presentation, and congratulations, Aisha, and also Mary. I guess my question is like, obviously this is a superb program, and how applicable are they to other large programs across the country? So I guess the question might be for you, Leo, and for Saint-Justine and from Montreal and other large programs who handle a lot of these patients on warfarin. So can I direct them to the audiences as well as to you, Leo?
Yes, but Mary and Aisha, perhaps we can start by having your comments about John's questions about applicability, generalizability, and how you foresee this being translated into other programs, if I followed your question, John.
Yeah.
So I'll speak to that just a bit. First of all, I have to say that really Mary's been a leader in this area and has really pushed for the development of this program based on the adult results, and really I think our program's success has been largely based on her expertise and her drive, but now that it's set up and we have a model of care, I think it's actually fairly translatable to other centers, and I think Mary would have a lot more to add on that.
Yeah, I agree. I think it really is. When I'm invited to speak on this frequently, and it's always the same question: how do you get your meters? How do you get it started? Within our program, I started with, as I said, a very small grant. I got 10 meters. It was one of our very initial studies in 2005. And we looked at time and therapeutic range as a primary outcome. And the results were quite significant then in comparison to previous. Our model of care is that we have meters and we loan them to patients for a year. And they sign a contract saying they're responsible for caring for the meter. Once they've had it for a year, they have a choice as to whether they purchase the meter at that point in time, or whether they want to return the meter and go to lab testing. There's rationale behind that. And initially getting a patient or a child into therapeutic range, the INR testing frequency is much higher in the first 6 months than it will be down the road in general. And so this provided them the use of a meter up front. Now, in having said that, we have not had one family yet who have declined to purchase the meter. So what happens is they purchase the meter, it allows us to buy a new meter to replace that meter, which then goes into, is provided to the next child with the same kind of setup. In addition, we presented our results to Alberta Health Services and Stollery and the Stollery Foundation. And they have provided funding for test strips for families who aren't able to afford them. So that's been a very positive thing as well. And in addition, families have been so excited about the use of these meters that we've had multiple donations. So I think it is very translatable. I think it means you need to start small. When you're purchasing the meters, if you're purchasing 10 or more at a time, you can get a really good price from Roche. So I think it is very translatable. Over the 10 years that we've been growing this program, we've had a lot of opportunity to work out the kinks and the things that don't work and the things that do work. I think that has really helped a lot. And we would, if it was something any program wanted to pursue, we would certainly be happy to be available for a resource. And the publication that will be coming out is actually quite detailed in terms of how exactly to set it all up. So.
Mary, could you make a few more comments on, let's say, how you divide your education process as you're trying to make the candidates for self-management proficient and
Okay.
more able, amount of hours, number of visits?
Oh, yeah. So, like when they first leave the hospital, before they go, they are taught on the meter itself, and that testing is done right up front before they leave the hospital at discharge on their anticoagulation for a Fontan or valve, whatever the indication might be. And it's quite in-depth. It's about an hour and a half of the nurse's time, and we have our handouts as well. So that training has already been done. Then they come, when we're starting patient self-management, to a clinic. They go through their general knowledge testing again with Warfarin alone, and then we do this interactive PowerPoint classroom session, which is about an hour and 15 minutes-ish. Kind of we all take turns talking and educating and go through case scenarios and everything else, and they get a dosing algorithm as well to start off with. Then there's a 3-month lead-in period where if they're found to be, we think that they're acceptable candidates for PSM, they haven't failed every question that we've given them kind of idea on their Warfarin testing, we do a 3-month lead-in system. Apprenticeship, exactly, where they phone in with the INR, but just like a med student would or such, they tell us what they think they should do. And there's no wrong answers, but we help guide them to the correct answer. And so they learn with every INR for that 3 months. And then at the end of the 3 months, there's an evaluation. They always say, yes, they're good to go. They're feeling confident. They're feeling secure in the decision as well. And we're feeling secure about their management process. And then they feed into the PSM program after that.
We just had a clinic last week, and we really focus on DIME. Warfarin can change on a dime. One of the things that most commonly affected is diet, illness, medication, and errors. And then we kind of expand on each of those things. We reinforce it so frequently within that 1-hour education session that there isn't a person who goes home and doesn't know that Warfarin can change on a dime and what DIME is. The other thing is that we do a lot of dose calculations in case scenarios. And so they get a lot of practice with different target INRs, different dosages, different INR levels, and how to respond. And finally, and I think what's most important, is that families know their children best. They know what's going on in their life. They know their historic response to Warfarin that we may not remember because we have hundreds of children and we can't remember whether they're more sensitive than another. But families understand that and they know that. And when they're responsible for making those decisions, they pay attention to that. And so they actually do better than we do. So our time in therapeutic range, if I recall, was 92%. And when we compared that to our patients that we were managing in the first empowerment study, we only had 84%. So parents do better than we do because they know their child best.
Fantastic. John, do you have any further questions? Probably John is gone. We have another.
I'm still here, but I don't. Thank you.
Okay, thanks. So we still have another person from BC. I don't know if she's able to No, she's gone. I'll move to Calgary. Mark Belletruti and his site. Are there any questions from your site, Mark? No questions from Mark, or not able to send anything? We'll go to the next. Amber Smith, also in Alberta. No questions. My apologies. I'll go to then Runa Singha. Runa?
No questions for me, but it's very interesting because we're just trying to start up a point of care program here. So educational materials I'll definitely be approaching you for. So thank you.
Thank you very much. Next attendee now in Ontario, Melissa Morrison. No questions. Then let me ask Sick Kids. Are there any questions from the floor here in Toronto? Okay, no questions. Mary, I'll take the privilege of holding the mic. You said this program developed over a 10-year period.
Yeah.
Would you mind sharing a little bit more information in terms of, so first of all, this is an example because you, as you're, maybe share with us, as you were transitioning from nursing role to nurse practitioner role, to what you judge that is okay to share, the amount of support you had from the hospital, and this is really an example of what nurse/nurse practitioner in terms of clinical care and research, how you can influence for other programs in the country. Maybe share some of your thoughts on those lines.
I think that within the nurse practitioner role, there are 4 or 5 domains of practice, however you look at it. And they are clinical, education, administration, and research. And they're really like 4 circles that overloop themselves. I think my initial interest in self-management was entirely personal. I had a daughter who was diagnosed with type 1 diabetes and then insulin therapy, and within 24 hours, patients are discharged home and are told to follow an algorithm and manage their own insulin. And I thought to myself, well, if they can do that with insulin, which can kill you in moments, we certainly can be doing this with warfarin. So that was really what started this. I was initially involved in the outpatient program alone. Now I essentially manage the outpatient program and do clinical inpatient stuff. But my research focus has always been the clinical practical-based approaches to antithrombotic therapy in children. And so warfarin was the very first one we started, and we started off with patient education and evaluating patient education, and then self-testing, and then self-management. So that's how it's really grown. I think as a nurse practitioner, you are an independent practitioner who practices on your own license. And I think the exciting opportunities that come with that role is the ability to direct research questions and to lead investigational studies. So I think all nurse practitioners can do it, but I will say having some dedicated time to do that is absolutely necessary. You can't do clinical 5 days a week and do research on top of that. It has to have dedicated time.
Thank you, Mary. Let me make sure that I've crossed those T's and allowed any questions from floors or from attendees to be shared with you guys. And I don't see anything else on the screen, and we don't hear anything. So with that, I would thank everybody that joined the session. Oh, apparently there's Sick Kids. Let's just make sure. Is there any question from the floor here in Toronto?
We just wanted to let you know that there is no questions, Leo.
Thank you. So with that, I would thank Mary and Aisha again, announcing that there will be another webinar next week by Dr. Bussell on the use of EPO-mimetics in children. And thank you very much for attending. Hoping to have your presence next week. Thank you very much.